freshly erupted incisors like human incisors or human premolars. They're closer. So you can decide what mode you will use. Do you want MSP or QSP? So this mode is fastest, and if we took it as a standard, we calculate the delay according to the operation mode that I showed you in previous charts. High speed is lowest, and there is significant difference only in the hardest, I told you, in the premolars. So if you want to use QSP mode, it's better to use it in the rear zones in the mouth, where it really needs this. And these are some clinical cases, so I will go faster because I see the time is going. This is the old filling removal. You see the discoloration on the borders. This is the new filling done, and this is the preparation. I made a separate slide to see it clearer. You can see how clean is the border when it's etched with the QSP mode, because it's a really advantage that you don't extend the cavity in the sound enamel. This is the class 5 cervical filling. It's the smallest. It's a small cavity. I did it without anesthesia, and you see there is very little bleeding because of polishing the filling. This is case with anesthesia, but it's done in seconds. I begin with this mode, 500 millijoules, to remove the caries dentin. In the beginning, you see the result after 500 millijoules. It's done in 5 to 7 seconds. It took me. This is the whole preparation done with this mode, with 300 millijoules, 15 Hertz QSP. So how you can see how deeper it is. This, of course, is with anesthesia, and the filling is ready. This is a standard changing of filling. I will not lose some time. This is the case of preparation for changing the composite veneers. So first we did some bleaching. Then we removed the layer of the composite with this mode on 200 millijoules. And you see how the surface is looking. It looks very deep craters, but it's so high retentive for the layer of flow composite. And these are ready veneers done. This is the settings that I use for gingivectomy when I prepare some cervical caries. I decided to do it with QSP because of usually when you do preparation for cervical caries, like here, you do the first preparation, and after that you have to contour some extensions of gingiva, like here. So I decided to do it with the QSP mode because it's safe for the harder tissue, because if we go in very long pulse, we do some carbonization and changing the surface of the preparation of the cervical caries. So I did it with the QSP mode. You can see there is no bleeding after polishing, and you can see it on the next day. This is the next day slide. The gingiva is healed very well. The gums are healthy. This is the case of amelogenesis imperfecta. This is fluorosis. It's done without anesthesia on a very scared patient. This is the preparation. Again, you can see where the enamel is of high consistence of fluor ions. There is very hard to do preparation here, so I used the large pulse of 400 to 500 millijoules. again with the QSP, because with this mode we go deeper. This is a done obturation. This is soft tissue management. You see this gingival buccal connection. It's cut without anesthesia, only one point with non-contact handpiece because of this possible recession here. This is a phrenotomy and gingivectomy combined, again in QSP. And this is not QSP, but it's one approach that I decided to try and to see. It's done without anesthesia. It's a leukoplakia. It's a smoker lady. So I decided to start with a long pulse to cut some parts of the leukoplakia and then to smoother the surface with a very long pulse. And you see the settings with the long pulse. I used very low hertz rate and low average power with the 150 millijoules with slightly cooling of water. And you can see after the LP how some points we go deeper with the long pulse, and then with the very long pulse we smooth the surface and remove the lesion at all, and you can see it 1 week later. So I have one example of, I wrote it, this is fibroma, but today I got the histology results, and this was papilloma. And I asked my professor of histology to make some pictures, but he couldn't. But he just tell me that the coagulation zone is of 300 to 400 micrometers. So this is done with a long pulse and without noticeable coagulation in the tissue, so it heals very well. I will call it for the checkup. This is, you can see there is no carbonization of the sound tissue. And okay, we're almost finished. Thank you for your attention. You can meet the possibility of the LightWalker at your local dealer. Welcome everyone, and thank you again.
Thank you very much, Dr. Mironov. That was very informative. We really appreciate your time. I'm going to also, if it's okay with you, send your email address to people so they can contact you. Is that okay?
Of course, okay.
So I'm sending that email in the chat right now. So if you
I see. Okay.
If you would like, if anybody would like to email Dr. Mironov with any additional questions or just to find out more information about some of the studies he's doing, etc., please feel free to do so.
Yeah, we go further with some other studies and some clinical researches. And if someone wants some interesting picture or something that he saw today, and he can ask me more and more about my methodology, and if I didn't show some results, please ask me. I will have a picture of checkups in a week, or I can send it to everyone. It's not a problem.
Okay, there's one last question that says,
yes.
How would you compare your clinical results between the near-contact H14 handpiece and the non-contact HO2 handpiece?
They are almost the same, but I use a smaller spot to have a high energy density and a more clean cut. When I work in a soft tissue, I prefer to work it. But for example, when I do gingivectomy, it's better to do it with contact handpiece H14 because it's more safe for the enamel below the